So good evening, everybody, and thank you for joining us for our latest webinar from the East Sussex Eye Group. It's good to have you all with us. So many people have registered and joined. So this webinar is being recorded and will be available to watch later on the YouTube channel, the East Sussex Eye Group. There is one CPD point available for today's lecture. That is if you are watching it live from the link when you registered, and make sure you're watching it from your link. And the CPD point is available for optometrists and dispensing opticians. So the lecture will run for approximately about 45 to 50 minutes, with about 10 to 15 minutes afterwards at the end for questions. There is a Q&A box at the end, at the bottom of your screen. So if you have any questions, please type your questions there. And at the end of the webinar, I will then present them to Mr. Qureshi to answer. So I would like to welcome today's speaker, Mr. Kashif Qureshi. So Mr. Qureshi graduated from United Medical and Dental School of Guy's and St Thomas's Hospital in London in 1999. He then worked as an ophthalmologist for 13 years and became a fellow of the Royal College of Ophthalmologists. He undertook subspecialty fellowship training in diseases of the retina in the Northeast at Manchester Royal Eye Hospital and then at Moorfields Eye Hospital in London. Mr. Qureshi has a specialist interest in dealing with diseases of the retina, but also manages general ophthalmic conditions. He performs laser surgery to anterior and posterior segment, including the retina and vitreous. He also performs intravitreal therapeutic procedures and cataract surgery, including offering premium lenses. Mr. Qureshi has a variety of interests and profound knowledge to be able to treat disparate eye conditions that include cataracts, age-related macular degeneration, glaucoma, and retinal disease. This has guided his research into potential new treatment techniques moving forward. So, Mr. Qureshi, thank you very much for speaking tonight. I would like to hand over to you.
Thank you very much. Oh, look, there's Ian. Is that what can we all see that on the screen? I'm going to put, all I can see is Ian's lovely face on as a photograph still on the screen. I'm going to just share my slides now. There we are. And put it on slideshow view. Lovely. Continue to share. There we go. Hopefully you can all see that. So I am going to talk about referrals. Firstly, I just wanted to say thank you, Ian, for the very kind introduction, and thank you all for attending on a rainy, horrible Wednesday night. I'm sure this will be a bit better than the weather outside, I hope. I am one of the consultants at East Sussex, although I'm only there really one day a week nowadays. I am largely otherwise in a mixture of the private sector and independent sector ophthalmology, largely with a company called CES Medical, of which I'm the medical director. But on to the talk. Oh, hang on. How do I advance the slides, Ian? Ah, there we are. So, The Good, the Bad, and the Ugly. Great film. Many of you optoms are probably a bit too young to remember it, but I highly recommend you look it up. Classic spaghetti western. So that's me, consultant ophthalmologist. I'm still currently the clinical lead for ophthalmology in Sussex for the ICB, medical director at CES Medical, and I also, one of my other hats is I do medical legal work for a company called Eye Law Chambers, and I'm a director of that company too. So, what is the context of this talk? Well, we're talking about referrals. We're talking about how to write a good referral, and how triagers approach the referrals that are sent to us, and what is urgent and what is not urgent, and how one can assess urgent things in the community. And the context of this is that we're now in a situation where there's a massive increasing demand from patients for ophthalmology services, not just in the hospital, but in the community too. And there is an increasing reliance on optometrists as there's no capacity or expertise in general practice, and general practitioners will be very the first to suggest that they don't really know much about eyes. Their undergraduate training in ophthalmology is minimal. And optometrists actually do know very much about eyes. And I would also suggest, because quite a lot of ophthalmologists are stuck in their ivory tower in the hospital, they don't really see what happens in the community. I do work 2 days a week at least in the community in practice, which is an optometry practice where I see ophthalmology patients. So I've got kind of a foot in both camps, so I kind of see what happens on both sides of the coin. With regards to East Sussex, where I used to be the clinical lead some years ago, they receive about 400 referrals a week, and most trusts receive about that many referrals. So you can imagine it's a lot of work, a lot of referrals, a lot of patients that are being seen or requested to be seen. The triage is now often done as a PDF, an electronic system that we view a PDF, so it's a bit clunky and takes a bit of time to do. So poor triagers, when they're sitting there, they've got these clunky systems, 400 referrals to look through. So they really want to be able to look through things quickly and be able to make a decision about, is this urgent? Is this not urgent? Where does this need to be seen? What's the most appropriate setting for this to be seen in? And that's another thing to say, is that now the other obstacle for optometry in the community is that there are multiple providers. And lots of places, they have what's called a single point of access, where they have a single triager who triages for everyone, including the hospitalized service, including the independent sector providers. And they sort of are the arbiters of where these referrals go. In Sussex, they're a bit slow to adopt these things, and they're looking at a single point of access, but I'm very sure that they're going to adopt one. And more worryingly, it'll probably be an AI system. So, what is the goal of a great referral? So, you can see I like a bit of Dirty Harry and Clint Eastwood. What an actor. So, the point of this and the point of the clumsy picture is because it is a bit of detective work. And the goal is for the patient to get faster access, accurate triage, sorry, not tirage, triage, and a smoother journey so they're seen in the right place by the right person at the right time. And hopefully they get the right treatment. For the ophthalmologist, a great referral enables an efficient clinic flow, focused assessment of the patient, and no wasted time playing detective, like Dirty Harry. For you, as the optometrist or the GP, who's as a referrer, there's the peace of mind that you know that the patient's going to the right place, and that you're also building a stronger relationship with the specialists that you're dealing with. And often you get better feedback for your learning. Now, I know many systems like East Sussex, they don't really get much feedback. With things like Rego, they don't get feedback. But there are other areas where the systems actually do enable a direct feedback to the optometrist about their referral. So, who is the target? So, the GP or the ophthalmologist, you need to provide a reason for the referral, describe abnormal, unusual findings, try and use your language appropriate for the recipient, and indicate a time and a time frame or urgency for the referral. Remembering, GPs don't know anything about eyes, so talking about anatomical things with the eye or refraction, you might as well be speaking in Klingon to a GP. And I say that with a degree of a declaration of interest that my wife is a GP, so they really don't know a lot about eyes, and they don't really want to know about eyes. They've got more important things to worry about. So the golden one-liner. So this is one thing, if you forget everything else I've said, what I'd like you to go away with is, if you can remember the golden one-liner, this one sentence that can set the stage for the person who's reading your referral. It tells the triager exactly what they're dealing with and what its potential urgency is. So a bad example, please see this patient with eye problems. And I know you might be laughing at home thinking, oh, who does that? But trust me, that people do that. And the good, please see the 68-year-old diabetic with sudden painless loss of vision in his right eye. I'm concerned about central retinal vein occlusion. And as a triager, you think, brilliant. I know exactly what the problem is. It's very likely to be that. If it's something else, it's going to be something related to that, probably. That's pretty urgent. I need to see that urgently. Decision made. So the core components of a referral, the chief complaint, often in the patient's words, my vision is a bit blurred, my vision is misty. Remember, the patients don't always very well articulate what their actual problem is. And so it's sometimes useful to use their language rather than trying to translate it into what you think the problem is. Because sometimes it's not really what you think it is. A very good example of that actually today, in that I saw a patient today. I was doing a clinic in the community, which was a YAG laser clinic, NHS YAG laser clinic. And a patient had been seen by a colleague who is an optometrist and said, my vision is very blurry and misty and smeary. And the optometrist said, oh, you need a YAG capsulotomy, which is not an unreasonable thing to think. And he referred him for a YAG anyway. So he came, sat on the slit lamp, and I looked at him dilated, and there was no posterior capsule. He'd already had a YAG, in fact. But the patient was indeed, the vision was reduced, and his vision was indeed misty and a bit foggy. So then I looked at his notes, and then I looked at the back of his eye, and his cup disc ratio was about 0.95. And his field was almost completely wiped out. And when I looked at his visual fields over the last sort of year, they've been slowly wiping out the central part of his visual field. And that's why his vision was reduced. So often, if you just say what the patient thinks rather than what you think it is, you might get the answer. So the history of the presenting complaint. What's the onset? Was it sudden? Was it gradual? How long has it been going on for? What's the laterality? Is it one eye or is it both eyes? Is it painful? Yes or no? What's the character of the pain? Dull, achy, sharp, stabbing? Any associated symptoms? Redness, photophobia, floaters, flashes, discharge, headaches, anything else? Remember a medical history. Now, I know, excuse me, you're not medics, but you do have some medical training to an extent. And you're also well aware that many of the diseases that affect the eye affect the rest of the body. And it's important to make reference to that and to be aware of it and to comment on it. So systemic diseases, in particular, things like diabetes, giant cell arteritis, any autoimmune diseases, things like thyroid eye disease, or anything else you think might be relevant, is worth making mention of, at least in your referral. Ocular history, previous eye surgery, previous history of glaucoma, any traumatic injuries. And by previous eye surgery, also the important thing to remember is laser refractive surgery, which of course is becoming more and more prevalent nowadays, and particularly the patient group who had a lot of laser eye surgery in their 20s about 20 or 30 years ago are now in their 50s and developing other sorts of eye problems. So it's worth mentioning. Medications and allergies, particularly eye drops and systemic steroids. So, that's always very useful context for the ophthalmologist to know what medications they're on. Some medications, of course, can affect the eye. Some medications can be relevant for things like, for instance, if we're doing cataract surgery, if a patient's on tamsulosin or an alpha agonist like doxazosin, that will cause floppy eyelid syndrome and make the pupil less likely to dilate. So these are things that are important for us to know, and it's worth documenting it. I know that the difficulty is in the community, often you're rushed, you haven't got long to take all these details down, but if you can, please do. Important thing to also say, as a bit of a plea, is to do what you can do. I know that sounds stupid, and I think for most of you who are in a community and are working, or very diligent and hardworking, you wouldn't even dream of not doing these things. But trust me, it happens that people are referred having not actually been examined at all, often, or at least the examination bears absolutely no relationship to what's been written down. So a visual acuity is non-negotiable. So quite often we get referrals. Maybe it's an error of forgetfulness, but we get a very detailed refraction, but no VA, which is great, but it doesn't help us really in knowing what their vision is. A refraction is helpful, particularly if it's something that you're dealing with that might be a refractive cause of a problem, such as a cataract. It does stagger me now that you get lots of referrals for cataract surgery in patients and there's no refraction attached. Now, it's not the end of the world. It's not that we can't do cataract surgery without a refraction, but it does help, not least to at least discuss the refractive outcome with the patient if we know what their refraction is in the first place and what they're used to. It also makes us look a bit less of an idiot when we try and explain to the patient, what their outcome can be, and they tell us, well, no, I've been short-sighted my whole life and I want to remain short-sighted. Pupils, check for an RAPD, check for pupillary responses. An anterior segment exam, it can be very basic, but is there a red eye? What's the character? What's the pattern? Any other features? The lids, blepharitis, meibomian gland dysfunction. It is amazing how little attention people pay to the eyelids, and in particular the meibomian glands. I would say probably 70% of the pathologies of the front of the eye are often, in the community anyway, are often related to the meibomian glands and the lids, and often people don't look at them. And don't be afraid to touch them either. Look at the lid, look at the laxity of the lid. How is it opposed to the globe, etc., etc. A dilated fundoscopy. Look at the back of the eye. Look at the optic disc. Best to do it with a patient dilated. You get a stereoscopic view. Look at the macula. Look at the periphery. Look at the vitreous. Now, I know those things are not always absolutely possible to do, but do what you can do. It is appreciated at the other side. But then also you've got to be a bit realistic about the referrals that you're sending and what your expectations are. So this referral, Mr. X came in complaining of intermittent right eye vision loss episodes lasting 10 minutes. Experienced 3 episodes in the last 6 months, the last one occurring then. Sitnap examination unremarkable. Please can you see this patient as an emergency? But his vision is 6/7.5, 6/6. Pressure's fine. Optic disc severe, fine. I mean, why is that an emergency? What is an emergency about? It's probably not really realistic to expect that to be seen as an emergency because you've not actually presented the triager with a reason why this might be an emergency. This sort of speaks for itself. I can almost imagine on Zoom the gasps from people looking at that referral. But honestly, that is a referral that came to me as the triager. Please, I can't even correct the capital L. Can you rule out OAG? No comment on the disc, no comment on the fields. Pressures are completely normal. I mean, actually, that's pretty disrespectful, that sort of referral. That just shows the triager that the person who wrote it can't be bothered. And it reflects quite badly on them, really. And I'm pretty sure most people wouldn't do this. I flagged it up because it's quite remarkable in how poor it is. Also, try and write clearly in words that people can quite understand. I understand that the need sometimes for people to write in abbreviations and to make things slightly shorter and more palatable and understandable, or write it quickly or type quickly. I mean, hopefully with AI dictation things, people won't necessarily have to type all their referrals. But I mean, really, this is, again, I don't know what it means. Joan complains of reduction DV. I'm presuming that means distance vision. OPH flat, healthy Bs. Well, healthy both eyes, but what does OPH mean? AMLAS changes, left eye OCT normal. So presumably the AMSA shows some distortion, but the scan looks normal. pH no increase left eye, so no improvement with pinhole, maybe. But I've had to, exert some mental gymnastics trying to read this to try and understand what he's actually meaning. What's he asking? What's the question here? again, it's just a bit disrespectful, to be honest, of a fellow professional that you're sending this referral to, and you're asking for them to help you. Oh, hang on, that was the wrong one. So this one, Mr. So-and-so came in for a routine check. Okay. Fundus examination, both disc margins appeared flat with moderate deep cupping of 0.55. Well, I mean, 0.55 is normal. Right eye showed possible notching superiorly. Well, it either does or it doesn't. Visions were unaffected and visual field plots were normal. I'll be grateful for you to routinely refer for a second opinion. I mean, I've attached fundus photos. I should have put the fundus photos. Photos are completely normal. So, you know, what for? Why are we seeing this patient? What is the point of this referral? Is the really subtext here the ability of the optometrist to interpret optic discs and what they look like, and when they look abnormal? I mean, it's difficult because, you know, they obviously thought there was a problem, and they were a bit worried about it. But, you know, you have to kind of question, when everything else is normal, the fields are normal, what is it that you're actually asking? And is it reasonable to send it as a referral, as a one-off thing? Could you, for instance, have followed this patient up and reviewed it at another time? Could you have brought it back to a senior colleague to ask them to have a look at it? That kind of thing. But, you know, there are things which are emergencies in ophthalmology. Not many, I'm pleased to say, which is why I'm an ophthalmologist. Haha. But there are some. And there are some things that need to be seen on the same day. And there are things that can be seen sort of within a week or so, or during a week. So same day referrals, I think, there may be some disputes about this, but I'm pretty sure that this is a agreeable list. So acute angle closure, obviously. Orbital cellulitis, I mean actual orbital cellulitis rather than preseptal cellulitis. A central retinal artery occlusion within 12 hours of duration, because then you've got a chance of dislodging the clot and potentially rescuing a patient's vision. Chemical burns, endophthalmitis, and a corneal ulcer, particularly an infective microbial ulcer rather than a marginal keratitis. I say that these are same-day referrals, but I have, where I work, there are units, hospital eye service units, who have refused to see one or more of these patients who've attended as an emergency, and they've sent it out to the community where I've had to manage them, which I think is unforgivable, frankly. Within a week, sudden painless loss of visions, such as a retinal tear or a detachment, retinal vein occlusion, giant cell arteritis, trauma with hyphema. I would say within a week is a bit optimistic. I would say those things need to be seen pretty quickly, as in within a day or two, or maybe rather than necessarily the same day. Then there are lots of non-emergency referrals, and these are things that are probably the majority of what you're going to be dealing with. So glaucoma is probably the biggest, or one of the biggest, apart from cataract, of course, one of the biggest sources of referral, or patients that need to be referred. And NICE guidance has been updated since 2017. It requires central visual field assessment using standard automated perimetry with full threshold or super threshold perimetry, optic nerve assessment using a slit lamp, and an OCT if available. But the thing I always bang on about, and I know other people have done this, I've seen this on social media, is please don't refer simply based on an OCT scan that looks like it's red, because it's often wrong. It's often based on how the circle is lined up on the optic disc. Also, remembering that the graph is comparing patients against a normative database of European people. So if you're not European, it's not really relevant in many ways. It's helpful, but it's not by any means diagnostic, and it shouldn't be. If everything else is completely normal, when you look at the optic nerve, it looks okay, I wouldn't refer on that basis. Pressure using, I've put Goldman, this is probably a bit of an, and that's nice guidance, but to be honest, nowadays, eye care is probably just as accurate, I think. as Goldman. I think very rarely do you find a discrepancy between Goldman and eye care. If you're really flash and you've got a Reichardt Aura, one of those very, very accurate air puff ones, use that because that's just as accurate as Goldman. Then looking at the peripheral anterior chamber configuration and the depth and depth assessment of the anterior chamber. If you can gonio a patient, do it. Wonderful, really good thing to do, brilliant skill to have. But I recognize that that's not something that many of you will be doing in the community or want to do in the community. So you can use Van Herrick. Try not to re-refer patients that have been discharged unless their situation has changed. So quite often the common situation here is you've got a patient who has been seen, referred to the hospital in the past for high pressures. They've been found to have thick corneas. The corneal thickness measures sort of 600. Their pressures are sort of 25. Try not to keep referring the patient back because there's nothing wrong with them. It's just you're getting an over-reading of their pressure. So you're kind of medicalizing them when they don't actually have a problem. Other conditions like wet macular degeneration usually last less than 3 months. History, patients report vision loss and spontaneously report distortion, often with missing patches and blurred central vision. Do a best visual acuity, best corrective visual acuity, including a near vision. Sometimes if you refract them, you find a unilateral plus shift in their refractive error. And of course, if you give them an ambular grid, you'll see it's all wobbly and distorted and wonky. Do a fundus examination with a slit lamp or an indirect ophthalmoscope, ideally dilated if you can. So this one came across me the other day. It's an interesting question, really, is whether you think this is a reasonable referral. I'm not sure. So this patient's got an amblyopic right eye with a mature cataract, intraocular lens in the left eye, got dry macular degeneration with some drusen and a PED, and has been referred for a routine assessment in the medical retina department because this is her only eye, effectively. But there are some retinal changes. I mean, I was a bit sort of slightly flabbergasted because the thing to think about is how many patients have got dry macular degeneration in the UK? Probably about 1.5 million people. How likely is the hospital eye service to see every patient with dry macular degeneration? Not very likely at all. I understand that this patient may have some signs which lead them to have a slightly higher chance of converting to wet macular degeneration. But when is that going to happen? Or how can you predict that's going to happen? You can't. It's like pinning a tail on a donkey. So how best can you manage this patient? Well, the best way of managing this patient is in the community, is to give them instructions. Look, if you start noticing any distortion, blurring of vision, anything like that, you come back to me straight away and I'll have a look at the back of your eye. And if it starts looking active, I will refer you to the hospital and they can do the treatment. And that's where I think you guys can come in. You can do that. You can give them, guided instructions on what to look out for, because that's your gift. And you can see them a lot more easily than they can be seen in the hospital. Remember, they're local to you. Often they have to travel miles to see us. And wait hours sometimes, not in my department, I'm pleased to say, they don't wait very long at all, but in many departments they wait hours to be seen. They're often elderly, they've traveled for ages, and actually you could very well just look at them in your setting and say, no, it's not active at the moment. Yes, I understand it's a bit more blurry. Other thing to say with macular degeneration is that there are in fact treatments for it now. For dry macular degeneration, such as the Lumathera and the 2RT laser. I'll talk a little bit about that. I don't want to detract too much. So people often say, oh, you can't do anything about macular degeneration. It's incurable, it's untreatable. You're going to lose your vision eventually. Well, this is a chap I treated with the 2RT nanopulse laser on the left. The first scan with the two big PEDs is before treatment. The second one is after a first session of treatment. And the third one is after the second session of treatment. And you can see the pigment epithelial detachments have disappeared, and his vision improved because of distortion, getting better. This is another patient who's had one session of treatment. She had these 3 sort of Loch Ness monster-like humps of PEDs, and now after one treatment, she's got one. This is a patient who, just as a nice on-fast view, has got all these sort of soft greyish confluent looking drusen here, had one session of treatment, and they've largely gone. So it can help. I would say, just going back, that I haven't, oh, hang on, I go back. Yeah. These are all treated with the 2RT nanopulse laser. I have started using the Lumithera treatment. I haven't had the same sort of results, really. It's been a little bit disappointing so far, but I've only had perhaps a year's worth of patients going through the treatment cycle, so it's probably too early to say. The nice thing about it is you can't really do any harm with it. It's quite easy to do, but whether it has the same level of effect as the laser, I'm not fully convinced still about it, but I think it's a really interesting option. And the other thing I would say, as another thing with for macular degeneration, is there are these infrared glasses that patients can buy online from a website called www.power.co.uk, and these deliver infrared light to the back of the eyes that patient can do at home. So it's not going to replace Lumithera or 2RT nanopulse laser, but it's a good adjunct, I think, that the patients can do at home. They can't do themselves any harm. It's just infrared light, but the radiance is much lower than with the Lumithera. So it's worth thinking about for patients. If in the community that have got dry macular degeneration, you can just point them to the website and they can go and buy them. I think the glasses cost something like 85 quid, so they're not very much. But anyway, my point on these 3 slides, apart from promoting my amazing results in treating dry macular degeneration, was to say that there are actually treatments available. And in fact, there are some of you lot in the community doing Lumithera, as I've seen in Crowborough, Haywards Heath, where else? Sevenoaks, Tunbridge. I welcome you to do it. And if you require any help from a macular specialist, please don't hesitate to email me. So retinal vein occlusion, another condition that's pretty urgent, actually, in the scheme of things. And this happens because there's an obstruction of the central retinal vein by usually a thrombus. In the central retinal vein occlusion, the thrombus happens in the central retinal vein, passing through the lamina cribrosa in the center. In a branch retinal vein occlusion, the thrombosis occurs at a crossing between the artery and the vein. And in a hemiretinal vein occlusion, it can be involving the superior or inferior hemiretina. It does need to be seen, I think, within a week. And patients will need medical investigations, but those medical investigations can be done in the hospital and arranged by the hospital. In fact, the one thing I've seen, and the hospitals actually promote this, and it's very naughty, is to say, to the GP has to do X, Y, and Z. The GP will get really pissed off with you if you tell them that they need to do X, Y, and Z. You can suggest that they need to do certain things, but investigations like an ECG or an echocardiogram or a carotid Doppler ultrasound scan, these are things that the hospital eye service can and should arrange themselves. They don't need to be done by a GP. And the blood tests. The GP can certainly act on the results of these things in the shared care process with the consultant, but not necessarily be expected to manage them on their own. Flashes and floaters. So posterior vitreous detachments, the commonest reasons people get flashes and floaters, incredibly common. 50% of people over the age of 60 develop a PVD. So it's a normal process of human aging, really. And what happens is the posterior hyaloid separates from the retina where it's attached at the vitreous base and around the optic nerve head. And this is a beautiful photograph where you can see the posterior hyaloid face lifting off the macula and above the premacular bursa, and still attached to the optic nerve head there. Syneresis is just the natural aging changes of the vitreous, where it goes from being a more liquidy, a more jelly-like structure to a more liquid-like structure, almost like like a balloon filled with little balloons filled with water in it, floating around in your eye. These represent connective tissue stuck together. People, of course, get excited about these because they can lead to retinal tears. So where the vitreous is attached firmly to the retina, generally is around blood vessels and at the vitreous base. And sometimes when it pulls off, it can tear at the retina. And there's a nice picture of retinal tear with a bit of subretinal fluid, which you can see on that photograph. And the consequence of that, as you know, is pigment cells in the anterior vitreous, sometimes blood in the vitreous, and a retinal tear when you examine them with dilated fundoscopy, and you do need to dilate them to look. Sometimes you'll see lattice or a round hole with new symptoms, and that might need treatment. These patients do need to be referred urgently and ideally seen on the same day or the next day, or within a couple of days anyway. The one plea I would make is to try not to game the system. I have seen this where patients have a PVD, have no tobacco dust, nothing at all, but the optometrist has written, tobacco dust seen, because they know that we'll then have to see the patient, and then they don't have it. And you think, well, that's a bit of a bum move, really. Pigmented retinal lesions, choroidal nevi, the most common of these are freckles, like you get anywhere in your body. These are benign melanocytic lesions, symptomless and often found completely incidentally. Very occasionally, they can even be associated with macular edema or subretinal fluid and some neovascularization, but very occasionally. They're distinguished from a melanoma because they have clearly defined margins. They're flat, they remain stable in size, they've got overlying drusen sometimes if they've been there for a long time, and some RPE atrophy, hyperplasia or fibrous metaplasia. They need a routine referral. They don't need to be seen with any urgency. And please, when you do refer them, don't write something like, please exclude a malignancy, because the patients then cack their pants when they read that, because they think, oh my God, I've got cancer. And then when they get an appointment in 6 months, they're not that impressed. I mean, if they've got features which look like it might be a malignancy, then you can say it, but don't say it if it's a completely flat nevus. When you are referring a patient that has got a suspicious lesion that you might think is suspicious, please remember the mole scoring. So mushroom shape is the M. So 2 points if it's a definitive mushroom shape with an overhang, 1 if there are signs of early tumor spread through the RPE, or 0 if absent. O, orange pigment, 2 for confluent, easy visible clumps, 1 for subtle dusting, 0 if absent. L, large size, score 2 for significant thickening more than 2 millimeters, or diameter more than 4 disc diameters, 1 for a subtle dome shape or diameter, etc., etc. E for enlargement, if you've got a comparison photograph to show that it's enlarged, and S for subretinal fluid. You can look that up. That's something that you can find if you just Google mole score. But every time you refer a patient that you have a suspicion that might have a melanoma, maybe, please use this scoring system, because at the end of the day, the Regional Ocular Oncology Service at Moorfields Eye Hospital, that is how they're going to accept the patient. And that's how we will accept the patient too. But it is important to put it, if you do think there is something significant. I have just seen a patient 2 weeks ago who was seen in Sussex with a suspicious lesion, but the optician didn't really say that. They said there's an elevated large brown lesion in the temporal periphery, but didn't really make it very clear what that was. They got referred to Mason and Tunbridge Wells, but then rejected because they said it's a Sussex patient, because it was in, I think, Crowborough or somewhere like that, but not a Kent patient. Then it got referred to Brighton, which is a bit of a basket case, and the patient bounced around the system in Brighton and then got rejected by Brighton, and then ended up in my community service at CES Medical in Tunbridge Wells, and I saw her, and she's got a large elevated lesion in her temporal macula, which is probably, it's either a melanoma or I'm praying it's a hemangioma. But it's not absolutely clear that it's a melanoma, but I've got a high level of suspicion. And she's basically waited 6 months for an appointment, which is a bit unforgivable, really. Chirpy, I'm sure Shah has talked about this many times. These are round, circumscribed, well-pigmented lesions in the retina, often in the peripheral retina. They're not of any real significance. If you've got these multiple bare tract lesions, they can be associated with familial adenomatous polyposis, which is a gastrointestinal issue, but that's something for us to determine whether they need a referral or not. They've got a very defined edge of lesion, and it's a lot darker than nevus. And if you're going to refer it, just refer it routinely. This is the photograph, a sort of montage of the most unlucky patient in the world, showing all the sorts of things you can see in the peripheral retina, which can or may not necessitate referral. Retinal degenerations, retinoschises, which are very common, 2 to 4% of people over the age of 40. Retinal vitreous degenerations, lattice, nail tract lesions, etc., etc., etc. So there's lots you can see in the peripheral retina, but not all of it is sinister. Assessing the optic nerve head, that also seems to be another common cause of anxiety and referral. So interestingly, in Kent, I get loads of swollen optic nerve heads referrals. In Sussex, not so many. I don't think the population is that different. So assess the margins of the optic disc. Is it blurred or is it not blurred? If it's blurred, how much is blurred and where? Are there any obscurations of blood vessels? Is there any cotton wool spot suggesting ischemia or any hemorrhages? Is the cup obliterated or is it visible? What's it like compared to the other eye? Are there any spontaneous venous pulsations? What is the refractive error? What are the patient's presenting complaint and visual function? Have they got any symptoms? Now, I know the massive anxiety about these patients because of the Honey Rose case, which is a sort of apocryphal case. But remember what you can do, and remember what the optic nerve does and what you can test. So you can test the vision, you can test the color vision, you can test the peripheral vision, and you can test for an afferent pupillary defect. So differentials to think about if you've got a patient with disc swelling in front of you. If it's unilateral, inflammatory, could it be optic neuritis? Could it be demyelination, sarcoid, lupus, atypical optic neuritis? Could it be infectious, like something you always think of syphilis, everything. I know people think, oh, who can possibly have that Victorian disease? But believe me, it's incredibly common, or more common than you think. Sinus spread causing unilateral swelling, vascular problems, commonly non-arteritic ischemic optic neuropathies, or less commonly GCA or diabetes. Could it be compressive from a thyroid orbitopathy, or something behind like an optic nerve meningioma or a glioma? Or could it be an infiltrative lesion like a lymphoma or traumatic? The medical history would often be quite helpful with these sorts of patients. If it's bilateral, it could be idiopathic, but it could be secondary. And of course, the big one everyone worries about is, could it be a brain tumor? Could it be trauma? Could it be venous thrombosis or renal failure, or some certain medications like vitamin A, tetracycline, contraceptive pill, or lithium? So I think that's about all I'm going to say, because I think there are some questions racking up. And as Dirty Harry said, I'm not going to do an impression. Do you feel lucky? So that's it for me. So I will stop sharing my screen so that I can see your chat.
Thank you very much, Mr. Qureshi, for that very interesting talk. There are a few questions, but one thing, because when I was at university, I was at university like 10, 15 years ago, and a consultant there said to us, there's 3 things you should include in a referral. And he said, the first thing is the presenting complaint, why the patient has turned up. They've got blurred vision, they've got this, that, and the other. The second sentence, that what you have done. You've dilated, you've looked, or whatever. And the third thing is why you are referring. He said you should include no more than those three things. Now, some of those things can be longer because if you've done pupils, you've done colour vision, or whatever. But he said, but your referrals should be no more than three sentences of why you're referring. Would you? That was going back a while ago, and you know,
No, I
it,
think I think I
okay.
think it's reasonable. I think that if you've done more, it's helpful because I think probably the one thing I would say, not throwing shade on your age, Ian, but you're younger
Yeah,
than
go
me,
on.
is
Oh,
that
oh,
back in the day in the community, there wasn't a great deal you could do really, other than examine them on the slit lamp and a refraction. But nowadays in the community, people have got access to all sorts of clever things, OCTs, fields, machines, etc., etc. So I think if you've done stuff, I think it's worth including it and mentioning it. And I think also the other thing to say is, I mean, I think broadly the guy, that chap was probably correct in the sense that is important, and keeping it clear and simple is important. But I think the other thing that's changed a bit is that the relationship between uh, optometry and ophthalmology in the hospital, which is now a much more even, co-management type of thing, or at least I like to think it is. I know some of my colleagues don't behave in that way or believe in that, but they're the real dinosaurs. The reality is it is um, something that in the community now people are, we are working kind of hand in hand. So I do think it's important to put what you can put,
yeah,
but keeping it simple and sticking to, what the problem is useful. No one wants a massive essay, but then equally they don't want you to write, please rule out OAG.
yeah. So, shall we go through the questions? There's quite a few questions. So, if
Yeah.
you're ready. So, if red on disc OCT, field GHT borderline, discharge from HES, should we monitor in community 6 monthly?
I mean, it's a really good question, Jig. I mean, because you got to
I
wonder.
wasn't saying the name.
It does. It's a jig.
Yeah, but I wasn't saying it, but
All right, sorry.
because
Should I
of
not name and shame? Um, but it's not. I don't know. I wouldn't shame. It's a perfectly good question because you'd have to ask the question why that patient has been discharged because there's actually something potentially going on there. It does depend to an extent on what the commissioning arrangements are for these things. Because the other thing to say is you could argue um, that if you're not funded to see that patient and they're not willing to pay to be seen as a private patient by yourselves in the community, well, should you be seeing them? If they're expecting you to do this for free, they're not,
Mm,
or under GOS 18, you haven't got time. 20 quid or whatever it is you get for GOS 18 is pathetic. Then you probably don't want to do that really. But if you think that there is something potentially going on, and maybe the hospital got it wrong, I mean that does happen, believe me, then sure, you can see that. But it is tricky because it does depend to an extent on commissioning arrangements. I'm trying very hard, rather unsuccessfully, to try and persuade the commissioners that actually patients with kind of stable disease can be seen in the community by optometrists who are actually quite skilled and able to do this under the nominal supervision, perhaps, of a consultant. But we seem to be rather stymied by hospital colleagues who want to control everything, which is, I think, a shame.
yeah.
Next one.
So the next question I'll read out to you
Yeah,
anonymously, but his name's on here probably. If we have documented a small growth, enlargement of a necroidal nevus, but the nevus is about 1 disc diameter flat, no SRF and OCT, does that warrant referral?
probably not. I mean, if you go on the mole score, then no. It's not going to be referred, it's not going to be treated, we're not going to do anything about it. I mean, if you want reassurance that, it's being seen by someone and monitored once a year or something like that with um, uh, a detailed fundus assessment, fine, by all means. What generally tends to happen with these patients in the hospital, for your interest is that they're seen for 3 years, once a year. And if after 3 years it hasn't changed, we discharge them back to the community. So there's no point in them being seen forever in the hospital because you don't know when they're going to change. Remember, the risk of transformation of a choroidal nevus to a melanoma is 1 in 8,450 cases. So it's really rare. So, don't be worried about that.
How much do you charge for RT laser?
So the 2RT is done at the Centre for Sight in East Grinstead. That's the only place that I believe has the laser in England, I think. And they charge 2,000 odd pounds per eye, which is for 2 sessions in a year. So 2 sessions, and each session is a session separated by 6 months. So one session, 6 months later, another session, and then 6 months after that, an assessment.
So dry treatment's not available on the NHS, is it?
No, it's not. It isn't. And Lumathera is not available either, sadly, on the NHS, and it's not likely to be NICE approved or available on the NHS. But and dry macular treatment, the nanopulse is not available on the NHS. I'm sorry about that. It's all very unlikely that these things are going to come on the NHS simply because of the numbers of patients. Remember, 1 in 7 patients over the age of sort of 70 has got macular degeneration. That's a huge number of people. And these therapies don't always work in everyone. But it's worth a try. I think the Lumathera story is underpinned by the evidence base, although the evidence base is a little bit on the weak side, but there is some evidence behind it. I think it's worth exploring, and I think it's an interesting area. And I know a lot of optometrists are buying them in the community and are doing it themselves, which I think is fine. I've got no problem with that. The only reservation I've got about optometrists doing Lumathera is just their ability to interpret what they're seeing on the scans and whether there's a treatment benefit or not. I don't know. Some people are quite good and quite able to do these assessments and have got autofluorescent imaging and all that kind of stuff and can interpret it very confidently, but I suspect a lot can't.
So you think it's better to refer on?
I think do the treatment. I think it's worth involving a friendly retinal specialist in the care of the patient to monitor them. Whether that's in the private sector, on a payment basis or in the NHS. I mean, the NHS can be difficult because they're not really going to have capacity to see these people and monitor them in the NHS, but in the private sector, they definitely can.
Mm. So next question. Can you send the link for the infrared glasses, please? Where can I send patients for the macula? Can you send
So,
that? I can
well,
forward
the
on.
the the um the website is www.eye dash power power.co.uk. Shall I put it on the screen and then
Yeah,
share
you
that?
can probably get. Oh, I can send it out. I can
I
email
mean,
it out.
I hasten to add before anyone asks me, I haven't got any shares in this company. I wish I did, but I don't. It's just a good idea. Here you go. Let me hang on. How do I need to share my screen. An old man with technology. There we are. Share. Can you see that?
Yep, we can.
Yeah.
And
Yeah.
I'll move my questions aside.
Yeah. So
So,
iPower, eye-power.co.uk. And I think they cost 85 quid. So they're not expensive. And they work on the same principle that Lumathera does, which is photobiomodulation. And they're harmless and they can't do you any harm. And at the end of the day, the patients with dry macular, there's not a lot else you can do. So, particularly if they've got early disease, intermediate disease, you could give them the vitamin supplements, but don't just give them lutein. That's not enough. Give them other stuff as well. But this is another thing they can try.
cool. Right, I'll move on because we're running out of time.
Yeah,
The next question, I don't know if you can help with this. I will try and help. When patients are discharged from the glaucoma clinic with thick corneas, would it be possible to put the CCT on
yeah.
information letter to the GP optom? then we can make appropriate adjustments to our
I I
eye
I,
measurement.
I think that's a very good
Um,
idea, Ian.
I think, and I will mention that at the glaucoma meeting for our trust to see if we can do that. Um,
I don't see why not. I mean,
it's not on there really.
yeah, I'm surprised it's not on there either. All the other completely useless bits of information that get tagged onto those Medicite letters, that's actually a bit useful.
Yeah. So, next question, which is a bit of a long one,
Hmm.
and my varifocals are sort of not helping. In some cases, we have patients who, despite our advice and explanations, are very anxious and don't trust us and want a doctor's opinion despite us knowing there's no serious issues. What advice would you give to us in some situations we have no alternative to refer to a consultant, and some cases negative abuse behavior in fear of some repercussions or threats or even potential to missing something by this threatening information to our GOC license? I think that's about patient behavior, isn't it?
Yeah, I
Building
mean,
rapport.
I mean, it's difficult, isn't it? I mean, I think the thing is, don't just be calm. Just don't rise to it. That people are always a bit there. You know, a lot of people can be quite aggressive and hostile. Try and be charming. Try and be calm. Try and just reassure them, and try and explain it to them in ways that they understand. Often it's that they just don't understand what it is that the problem is, or isn't, as the case may be. I mean, occasionally there are cases where, you have to refer because you've got no other choice. The patient is insisting on it, and it is the patient choice at the end of the day. Um, but um, um, they need to be aware that if it's not something that the hospital sees or deems is going to be urgent, they're going to be waiting months to be seen. Certainly, some hospital trusts they will just reject the referral. They'll say, no, we're not seeing this because it's not something that requires to be seen. So I think you just have to just be calm. Don't rise, don't get angry with the patient. And if need be, perhaps a colleague within the practice can speak to the patient, or you can arrange a second opinion from a colleague within. But yes, occasionally you are going to be in situations if you're not sure and the patient is insistent that you do want to refer, and then you can refer. But as long as you've written precisely why the patient's being referred and there's some reasonable rationale about it, not that the patient's just a bit anxious, um, that's fine.
You had some aggressive patients, haven't you, really? We'll not, we'll move on. Where can we
Oh
get
yeah.
the Nano Pass?
Pulse, nano pulse laser. So that's the 2RT. So that is at the Centre for Sight in East Grinstead.
Does a
Um,
thrombosis originate from the artery pressure on a vein in the CRVO?
yes, it can. It doesn't always, but it can. Yes, quite often, in fact.
Thanks. At what point should we recommend the treatment?
I think this is probably they mean for dry AMD.
I think that's, yeah.
I mean, I think with the Lumathera, it potentially could be done at any stage, really, even relatively early. But I think you're less likely to see any treatment benefit until it's later on in the disease. But you don't want to leave it too late when they've got loads of atrophy. Otherwise, they're not going to be, you know, there's going to be, the gain is going to be a halting of the loss, if that makes sense, rather than, they're already going to have lost some vision by the time they've had treatment. But whenever, really you you can treat them.
Brilliant. Is the Nanopulse suitable for everybody with dry AMD?
No, it isn't. So there are some conditions like patients who've got something called reticular pseudodrusen, which is difficult to pick up if you haven't picked it up before. But it doesn't really work with those patients particularly well. It's not really understood why, but it doesn't. And obviously, if patients have got massive areas of atrophy, it's probably not going to make a huge amount of difference to them. I mean, there is some suggestion it might help delay progression of the atrophy, but in my experience, it doesn't have a huge modifying effect.
Cool. What else would you give apart from lutein for dry AMD? And I think this follows into the next question.
Yeah.
What is your top supplement recommendation for dry AMD? So,
So basically, the whole supplement story with AMD is based on a study called the AREDS 2 trial, AREDS 1 actually, and AREDS 2 trial, AREDS trial. This was done, age-related eye disease study. It was done about 25 years ago now. And it was a huge study across multiple countries, including the UK, America, Canada, Australia. And it showed that patients, if they were given a combination of various supplements, including lutein, zeaxanthin, copper, selenium, zinc, I think, vitamin A, C, and E, and other things in certain proportions, there was some evidence that that combination could delay the progression of dry macular degeneration from intermediate to advanced stage disease. That's it. It didn't provide any answer, any benefit in people with any early disease or people who've already got advanced disease. And lutein on its own is not enough. So you do need to take the other things. There are lots of commercially available supplements that have got all those things in them, like MacuShield, Ocuvite, Preservision, Nutrof. And they're all the same. They've all got the same stuff in them. It's just that some of them they've managed to make it into a small capsule that's easy to swallow, and some of them they're like a horse pill. Some of them are super expensive. Some of them are a bit more affordable. But if people have got intermediate disease, it's worth offering or advising the patient to do that. But if they don't, if they've got early disease, they might as well have a good diet which is rich in fresh fruits and leafy green vegetables.
cool. Can you stop sharing your screen, by the way?
Uh, Please could you provide details of the laser treatment to the website to direct to?
Yeah.
That's
I was
Centre for
very coming
Science.
to that one.
Shall I put Centre for Science website on?
Yeah. Put that on and then stop sharing your screen if you can. I'll close
Or
questions.
else,
Um,
hang on, where is it? Centre for Sight. There it is. There you go.
Brilliant.
This is Cheryl's Dayer's gaff, and I go there once a month.
Well,
Let me stop sharing.
thank thank you very much for that, Mr. Qureshi. That has been really entertaining and useful. I've enjoyed that, and it's been a while since you did the last one for us. So thank you very much indeed. To the people who'll be watched tonight, I will send the certificates out hopefully this weekend. Obviously, I do this. This is all free time, and it's all sort of I don't do it in work. I'm not paid for this, so I'm hoping to get the certificates out this weekend. Our next webinar will be advertised shortly on the WhatsApp group, and I'll advertise on Facebook and hopefully on other outlets as well. But thank you very much for joining us tonight. And Mr. Qureshi is reading his messages. That is what's on call tonight. Is it, are you on call tonight? Is it sort of like looking, saw you look at your phone there? Is it like,
No, it's just it's the uh, trauma of my son losing his property on the train
so I hope you
on his way
find
to school. I'm
I
sure
hope
all
you
the
find
other.
your equipment that's lost.
Yeah.
So thank you everyone for watching us, and thank you very much for Mr. Qureshi for tonight and for your time. And I'll advertise the next webinar soon. Your certificates will out hopefully this weekend, and I wish you all a good night. So thank you very
Thanks,
much.
guys. Thanks everyone for attending. It's very kind of you.
Thank you. Bye bye.
Bye.